Hello everyone and welcome to our second module on arthritis. Let's start by talking about septic arthritis, which is an infection of a joint. And a joint can be infected through one of several mechanisms. Sometimes bacteria can enter a joint through hematogenous spread through the bloodstream. There can also be contiguous spread from another source of infection. So a patient with osteomyelitis can have the infection spread to the joint. And then sometimes joints can be directly inoculated with bacteria, for example, after trauma or surgery. And usually septic arthritis is a monobacterial infection. The most common cause is Staph aureus, including MRSA. Other less common causes are streptococci and sometimes gram-negative rods. Septic arthritis usually presents with the acute onset of arthritis symptoms, and the acute onset is important for board questions. If they tell you a patient has developed arthritis over the last couple of days that is severe, that makes septic arthritis more likely. If the patient has had arthritis that has developed slowly over months, that's more likely to be osteoarthritis or some other cause. Usually septic arthritis is a monoarthritis, so it presents with a single swollen painful joint. The knee is the most common joint to be involved. Less commonly, the wrist, ankles, or hips can be involved. And then patients often have a fever because this is a bacterial infection. Some of the risk factors for septic arthritis are shown on this slide. One of the important ones is pre-existing joint disease. So patients with RA or osteoarthritis or gout are more likely to get septic arthritis. And so just because a patient has a history of one of these joint conditions, that doesn't mean they can't have septic arthritis on top of that. Intravenous drug use is a risk factor because this can introduce bacteria into the bloodstream, and then immunosuppression is a risk factor, including diabetes. Sometimes infants can develop septic arthritis. This usually occurs in the hip or the knee, and babies obviously can't tell you that they have a painful joint, so they will present with fever, irritability, and poor feeding. But then on exam, there will be a swollen, red, warm joint with joint tenderness to palpation. So examining the joints in any baby who has a fever is an important part of the physical exam. The two diagnostic tests you want to order in a patient with suspected septic arthritis are blood cultures and synovial fluid analysis. You should send these before antibiotics are administered because antibiotics can interfere with the test results. Usually when you aspirate the joint, the synovial fluid white blood cell count will be in the range of 50,000 to 150,000. This table on the bottom of the screen I talk about in the first video on arthritis, but in septic arthritis, usually the white blood cell count is over 20,000, often up to 100,000, and mostly there are neutrophils in the white blood cell count. The fluid you aspirate from the joint is often purulent, which means it looks like pus, and then you send the blood cultures and the synovial fluid for gram stain and culture to identify the organism. Treatment involves antibiotics, but also drainage of the joint. This is similar to management of an abscess. So in joints that are easy to access like the knee, sometimes you can aspirate them serially to pull out the purulent fluid. In other joints that are harder to access, sometimes arthroscopic drainage or arthrotomy, which are surgical procedures, are necessary. The antibiotics that are used to treat septic arthritis are usually guided by the gram stain of the synovial fluid. If it shows gram-positive cocci, then you're probably dealing with staph or strep, and so usually you treat the patient with vancomycin until you get sensitivities back for the bacteria. Less commonly, the gram stain shows gram-negative bacilli. In these cases, you usually treat the patient with cephalosporins like ceftriaxone or sometimes ceftazidime if there's concern that the patient could have Pseudomonas. So let me just make a general point on a patient that presents with the acute onset of a monoarthritis. In these cases, especially if the joint is swollen and it looks like an inflammatory arthritis, then the important test is arthrocentesis to analyze the synovial fluid. If you see crystals, then that patient has gout or pseudogout, which I talk about in another video. If you have a very low white blood cell count, that suggests non-inflammatory osteoarthritis. If the white blood cell count is 2,000 to 100,000, this is an inflammatory arthritis, and this could be due to a number of causes. It could be a crystal arthritis like gout, it could be septic, it could be rheumatoid arthritis, and there are other causes. When the white blood cell count is over 100,000, that's usually septic arthritis unless it's proven otherwise. It's very uncommon for anything other than septic arthritis to make the synovial fluid white count this high. And then rarely in an acute monoarthritis, you can identify blood or fat in the synovial fluid. And when that happens, there's a possible occult fracture present that led to the monoarthritis. Septic arthritis of a prosthetic joint is a special type of septic arthritis with unique microbiology. The bacteria that are involved depend on how soon the arthritis develops after surgery. Early onset septic arthritis, which is less than 3 months after surgery, is usually due to Staph aureus or gram-negative rods. Delayed onset septic arthritis is septic arthritis that occurs 3 to 12 months after surgery. And in these cases, you have to consider coagulase negative staphylococci or enterococci. Coagulase negative staph in particular are very difficult to treat. They form biofilms on prosthetic joints, and they usually lead to a delayed onset septic arthritis. And then late onset septic arthritis, more than 12 months after surgery, has similar causes to septic arthritis of non-prosthetic joints, bacteria like staph, gram-negative rods, and strep. When patients present with an acute monoarthritis of a prosthetic joint, usually they're treated with broad antibiotic coverage until culture data is available. Often they're given vancomycin plus a broad-spectrum cephalosporin, and in many cases surgery is required either to debride the joint or to reimplant. Okay, next let's talk about disseminated gonococcal infection, which can cause arthritis. This occurs due to hematogenous spread of a Neisseria gonorrhea urogenital infection, and it usually occurs among sexually active adults. There are two classic clinical patterns of disseminated gonococcal infection. The first is the arthritis dermatitis syndrome, which we'll talk about in a second, and the second is purulent arthritis. And many times patients present with elements of both because these are really two ends of a spectrum of disease. In the arthritis dermatitis syndrome, patients present with fever, chills, and malaise, and they have polyarthralgia. They don't have arthritis, they just have joint pain. This involves small or large joints, and it can migrate over time from one joint to another. They can also develop tenosynovitis, which is inflammation of the tendons. Usually this occurs in the wrist, fingers, ankle, or toes. And then lastly, there are skin manifestations. Usually patients develop scattered pustules like these that are shown on this slide here, and this is the arthritis dermatitis syndrome. At the other end of the spectrum, patients with disseminated gonococcal infection can develop purulent arthritis. These patients present with the abrupt onset of monoarthritis or oligoarthritis. The knees, wrists, and ankles are most common, and so a patient with the abrupt onset of arthritis who is sexually active, you have to consider they could have a disseminated gonococcal infection. If you suspect disseminated gonococcal infection, you want to send blood cultures because there may be bacteria in the blood. You also want to do the usual mucosal testing that's done to identify gonorrhea infection. So you want to send urogenital, rectal, and pharyngeal swabs for gonorrhea nucleic acid amplification testing. And then arthrocentesis of the joint for synovial fluid testing is important. The white blood cell count is usually about 50,000, although it can be lower. You want to send the synovial fluid for gram stain and culture, although you should be aware that gonorrhea is notorious for having negative gram stain and culture even when it's the cause of arthritis. And so for this reason, nucleic acid amplification testing of the synovial fluid is often done because this is more sensitive than culture. The treatment for disseminated gonococcal infection is usually with intravenous ceftriaxone. Now, many patients who have gonorrhea are co-infected with chlamydia, so oral doxycycline or azithromycin is sometimes added to ceftriaxone to cover chlamydia co-infection. You don't need to do this if chlamydia co-infection has been ruled out by testing, but if the patient hasn't been tested for chlamydia, then one of these drugs is usually added to ceftriaxone. Okay, now let's talk about some other causes of arthritis. We'll start with Lyme arthritis. This occurs in patients who have Lyme disease, which I talk about in detail in videos in the infectious disease section. Lyme disease occurs in endemic areas of the United States, which is mostly the northeastern United States. And you should suspect Lyme arthritis in a patient who presents with new onset arthritis and has a possible exposure to Lyme disease. Lyme disease is a tick-borne illness and it occurs in endemic areas like the Northeast US. You should suspect it in someone who may have had a prior tick bite or someone who's been hiking and camping and could have been exposed to ticks there. If an arthrocentesis is done in a patient with Lyme arthritis, it will show inflammatory findings like we talked about earlier, but the gram stain and culture will be negative, and that's because the bacteria is very difficult to identify. The diagnosis can be made by Lyme serology, which I talk about in the infectious disease section, and the antibiotics you can use to treat Lyme arthritis are doxycycline, amoxicillin, or ceftriaxone. In another video, I talk about seronegative spondyloarthritis in detail. So the word spondylo means spine, so a spondyloarthritis means joint inflammation of the spine. And these disorders are called seronegative because they have negative rheumatoid factor. And the seronegative spondyloarthritis disorders are a family of disorders with common features that can include arthritis. All of these disorders are seronegative spondyloarthritis, and I talk about them in detail in another video. Parvovirus B19 can cause arthritis, especially in adults. In children, parvovirus usually causes erythema infectiosum, which consists of a rash that looks like a slapped cheek. This is a picture of a child here on the screen with erythema infectiosum. But in adults who are exposed to parvovirus, they can develop either arthralgias or arthritis. Sometimes they develop acute symmetric polyarthritis, especially involving the joints of the hands and the wrist. The diagnosis of parvovirus arthritis in an adult is often clinical, based on an adult who was exposed to children that may have had parvovirus. You can also measure anti-parvovirus IgM antibodies. There's no specific treatment. This is a self-limited arthritis, but this is a diagnosis you want to consider in any adult who works with children, such as in a daycare setting or in schools. Many children develop parvovirus infection, and then the adults who are around those children can develop parvovirus arthritis. Juvenile idiopathic arthritis is a group of inflammatory disorders that leads to arthritis in children under the age of 16. They all involve arthritis of at least one joint, and the arthritis will be persistent for more than 6 weeks. And this is important. In a board question of a child with one of these conditions, the arthritis is going to be persistent and have been around for several weeks. The diagnosis is clinical, and the treatment is with NSAIDs, steroids, or DMARDs, similar to the treatment for rheumatoid arthritis. And there are several subtypes of juvenile idiopathic arthritis, so we'll go through each of them now. In the oligoarticular subtype, children have less than 5 joints affected. That's why it's called oligoarticular. The peak incidence of this subtype is 2 to 3 years of age, so in a board question, it's going to be a very young child, and it's more common in females compared to males. Children often develop arthritis of the knees or ankles, and this can present as a toddler who has a limp and a swollen joint. Usually the rheumatoid factor test is negative, and one special thing to know about this subtype is that it does carry a risk of a serious complication, which is uveitis. This is inflammation of the uveal layer of the eye, and this occurs in up to 25% of children with the oligoarticular subtype in some series. The polyarticular subtype is similar to the oligoarticular subtype, but 5 or more joints are affected. This occurs in children either 2 to 5 years of age or 10 to 14 years of age. It's also more common in females than males, and uveitis can occur in this subtype, but it's less common compared to the oligoarticular subtype. And then the systemic subtype was previously called Still's disease. Children with this subtype of juvenile idiopathic arthritis have arthritis of at least one joint, and the onset for this subtype can be at any age before 16 years. The classic feature of this subtype, and the one you want to always remember for your board exams, is a high quotidian fever. Quotidian means daily, so children who have this subtype of idiopathic arthritis have one high temperature spike per day, but then their temperature is normal the rest of the day. So in a board question, they're always going to describe a child who has a very high fever, but then it goes away during the course of the day. Most infectious processes do not behave that way. Children with this subtype can also develop a rash. It's described as an evanescent rash, meaning it comes and goes. It's usually pink and macular, and this is a picture of what it can look like on the screen here. These children can also have things like hepatosplenomegaly and lymphadenopathy, but all of these things are going to bring to mind lots of other diagnoses. The key is the quotidian fever. This is a very unique feature of the systemic subtype of idiopathic arthritis. Besides all those things on the last slide, the systemic subtype can present with a high white blood cell count, elevated platelets, and an elevated SED rate. The ANA test and rheumatoid factor are usually negative. But once again, watch out for that high quotidian fever, that temperature spike once per day, with the temperature going back to normal afterwards. And then there is a condition called adult Still's disease, which is similar to systemic juvenile idiopathic arthritis, but it occurs in adults. So adults with this condition have polyarthritis, they have the quotidian fever, they can also have a rash. These things can resemble rheumatoid arthritis or lupus, but the ANA and rheumatoid factor are usually negative. And this is basically a diagnosis of exclusion once you've ruled out other more common things like lupus. And then I'll finish with one slide on transient synovitis, which can look like arthritis, but it's actually something different. This is a benign self-limited condition that usually occurs in children, and it's called synovitis because it involves acute inflammation of the synovium, which is the layer of cells that surrounds joints. It commonly affects the hip joint in children, and usually it's preceded by a viral infection. So in a board question, this will be a child who recently had an upper respiratory or diarrheal viral infection and now has pain in the hip. The child is usually well appearing. There may be a low-grade fever, but usually not a high-grade fever. And importantly, the white blood cell count, the SED rate, and the CRP are usually low and not elevated. In children who have a high fever or a high white count, you have to consider other diagnoses like septic arthritis. The treatment is with NSAIDs, and usually this resolves on its own over time. And that concludes our second module on arthritis.